All right, good afternoon. Hello from Chicago. Welcome, everyone. My name is Ryan Nagdeman, here doing a live broadcast from Rush University Medical Center. And today I'm chatting with Dr. Jennifer Earvolino, an internal medicine specialist at Rush, assistant professor in our Rush University Medical College. And thank you so much for joining us.
Thank you for having me.
This is great. So to get things started, tell us a little bit about yourself, Dr. Earvolino.
So I am a primary care physician here at Rush. I'm a general internist, so that means I take care of all adult patients. So I spend the vast majority of my time helping them manage their chronic conditions like hypertension, diabetes, heart disease, but we also spend a lot of time making sure that they're up to date on their preventive health care.
Preventive health care. And here we are in November, Lung Cancer Awareness Month, and so we wanted to take a moment to share information about screenings, such a life-saving tool and opportunity to like colonoscopies, mammograms. You have to come across this, Dr. Earvolino. Please describe lung cancer screening in your clinic.
So there's a couple things to note about lung cancer screening. It's relatively new, so we've really only started doing it since 2015. Whereas, as you talked about, colonoscopies we've been doing for far longer, mammograms. So primary care physicians are really used to thinking about that and advising their patients. But with lung cancer screening, it took us a while to get the data to help us to know who to screen, how often to screen, how to screen. So that data really came into effect. It was published and back in 2015 is when Medicare started covering the screening. So that's why we're trying to raise awareness, because it is a relatively new screening tool.
Okay, so we do the screening, and what does the screening show you?
So basically what the data showed us is that the best screening tool is a low-dose CT scan. Not chest x-rays, not sputum for looking at the cells, but rather a low-dose CT scan, so very low radiation to start with. And basically what we're looking for, in particular, are nodules that look like cancer. We tend to get back, I've ordered a lot of these screens now in the last several years, we get back a lot of different findings, most of which are benign. But what we're particularly looking for is anything that looks like a cancer, and what we're hoping for is, if it is a cancer, an early stage cancer.
Okay, and lung cancer screening is often associated with people who are smokers, and how do you determine who should get one?
So again, the data helped us on that. So to start with, smoking is the #1 risk factor for developing lung cancer. I cannot stress that enough. So, there are estimates anywhere from 80 to 90% of lung cancers are caused by tobacco, primarily cigarettes. And so when we were looking at who should we screen, there was a big question about how much smoking and such. So in the end, there are several trials that looked at all this, but currently what the recommendations are is that we only screen patients who are between the ages of 50 and 80 who have a 20-pack-year history of smoking. And by that, it's a very strict definition. So we get to the pack years by taking the amount that a person smokes in a given day multiplied by the number of years they smoke. So as an example, to get to 20 pack years, someone, if they smoke 1 pack a day for 20 years, that gives you 20 pack years. Likewise, if they only smoke a half a pack a day, but they've been smoking for 40 years, that's going to give you a 20-year pack year history as well. Again, it's what the data showed us is it's both the quantity, how much you smoke on a given day, and how long you've smoked that really factor into your risk. The last thing, in terms of people who are eligible for screening, they have to be either current smokers or having quit within the last 15 years, which sounds a little strange, but the reason for that is that when people quit smoking, they immediately start reaping the benefits of quitting. So within 5 years, we can demonstrate their reduced risk, and if someone has quit smoking cigarettes after 15 years, they've reduced their risk of developing cancer by 80 to 90%, which is huge.
Wow.
Yeah.
Talking about evidence and data, any evidence that men or women are more likely to develop lung cancer?
Historically, more men die from lung cancer, but of course, that's because more men historically smoked. Unfortunately, over the years, more and more women started smoking, and so now the numbers are becoming even. It's not really whether you're a man or a woman. Again, I'm kind of starting to feel like a broken record, but it's really the amount that the people have smoked. So if you look back at data, I think I saw somewhere back in 1965, about 42% of U.S. citizens smoked. Thankfully, now that's down to about 19%. But again, unfortunately, we see more men with lung cancer, but that's because historically more men smoked, but the women have gotten up there in the numbers as well. I will say lung cancer is the leading cause of cancer deaths in the United States. It far and away surpasses breast, colon, pancreas. It's a huge killer of people.
So with that, how big of a difference can it make if it's caught early?
So that's the beauty of these screenings. So whenever we're recommending a screening test, obviously we want to do something that we can intervene on and really make a difference. So what we found with the trials that we're looking at this, when we can catch a lung cancer at the earliest stage, that very early stage 1, it's great. So not great, but if I get back a scan that looks suspicious, I immediately am on the phone with my colleagues in thoracic. We get them into the operating room as soon as possible, and if it's an early stage cancer, their 5-year survival is 92%, and that's without any radiation, without any chemotherapy. Whereas, conversely, if it's a later stage, if it's the very latest stage, their 5-year survival is 0, and it's basically a linear curve. At every stage that you advance your survival, your 5-year survival goes down. But if we catch it early, which is the whole point of this, there's a 92% chance of cure, which is great.
That's fantastic.
Yeah.
In your profession, primary care, the importance of the relationship with your patients and as a patient, relationship with my physician. If someone believes they qualify for screening, where does that conversation start?
It really, as a primary care physician, definitely everyone should have someone. They should have someone that they're going to help them. They should be seeing them once a year. And certainly what's super important, we get triggered with our electronic records these days for some of those other cancer screenings that we already talked about. In order for the physician to be triggered to talk about it, electronically, that is. It's very important to have that tobacco history in there, but patients should know if they're a smoker in particular, if they have the kind of pack year history that I mentioned earlier, that 20-year pack year history. They should be having that conversation with their physician anyway, because it's not just lung cancer that the tobacco is increasing their risk of. There are so many other cancers that tobacco causes an increased risk. Heart disease, just to name a few. So at any rate, point is they should have a good relationship with their primary care doc. They should be honest with them. They should talk about their smoking, and then if they fall into this criteria, which is very straightforward, it's a super easy, it's easy to order, it's a low dose test, it's very easy to do.
So is there a different procedure for someone who's already exhibiting symptoms?
So in the world of medicine, so we look at tests, are they a screening test? And that's for someone who's totally asymptomatic. And in fact, for a screening CT, patients cannot have any symptoms. However, if I have someone coming to me that, say for example, has unexplained weight loss and has been coughing more and maybe coughing up a little bit of blood, something along those lines that has me much more concerned, they are still going to be getting a CT scan. It's just ordered a little bit differently. So it's a different pathway. They're still getting a CT scan though.
Yeah. Some, smokers, some candidates may be slow to seek help or seek treatment. The stigma of, I may have brought this upon myself, which happens. What do we tell them though, with a hope for treatment?
I always tell my patients, we're in a partnership together. And we probably have all done things we ought not to have, whatever in terms of our health. And that's, we do not think that way as physicians. And the whole point is if we can catch this early, we can cure you.
Yeah,
So no one should feel that way. And I mean, even the surgery itself, they've made advances on. When I talk with my thoracic colleagues, they now do something called a VATS procedure. It's a video-assisted thoracic surgery. 2 or 3 tiny little incisions usually is what it takes, like 1.5 to 3 centimeter incisions. Patients usually are out the next day. I literally just had a patient that I screened 2 weeks ago, suspicious nodule. She was in the hospital last week, went home the next day. You know, the recovery is just a couple weeks. It looks like we got it all, and you know, fingers crossed, she doesn't need any other treatment.
Well, that's fantastic. And as often as one should see a primary care physician, that's one. How often should I see my PCP? And then how often should I be thinking about screenings?
So the screenings are recommended. So we get back, there's actually, the American College of Radiology has very discrete ways in which we interpret the scans, but the scans are done once a year. Now, obviously, if we find something that maybe looks a little suspicious, but not worrisome enough to go to surgery, then we might do it a little bit sooner. But the screenings are once a year. In terms of how often to see your primary care physician, that would depend on kind of other health conditions that someone might have, but I would say at least once a year.
Okay. You touched on this earlier, the amount of patients that die with lung cancer. According to American Cancer Society, as many as 20% of patients were never even smokers. And so can we talk a little bit about the incidental,
Right.
that can happen?
Right. So so I've seen, differing numbers in terms of that. 10-20% never have had a tobacco history. So unfortunately, they are going to fall outside the screening criteria. But you and I were talking a little bit before this. I mean, there are other risk factors for lung cancer that aren't quite as clearly documented. And certainly having that conversation with your primary care physician, they may determine that because of, say, your extensive secondhand smoke, for example, or maybe some environmental exposures that someone might be concerned about, they may fall into where we can, either get a regular CT scan. There are some other payment options in terms of things, but it's worth having the conversation with your primary care doc.
Okay, great. A lot of conversation about smoking and whatnot. What's happening with the vaping? The vaping these days. So
It's funny. My husband said someone might ask me that question this morning. So, so here we go. So, the problem with vaping and and cannabis, that's probably the other one that people would want to know about. It's really hard to tease out that data. So, because not everyone clearly, but especially with the vaping, perhaps they smoked before and used it to quit or what have you, but so there's a lot of confounding variables, so we just don't know how risky those behaviors are. We do not have good data. Cigars and pipes do increase your risk of lung cancer, so just FYI. So
Are there any additional topics that you wanted to cover or that have come up throughout our chat?
I think the things that I want to stress, we've covered, but certainly, people should definitely have a good relationship with their primary care physician so they can have this conversation, for starters. The number one way to reduce the incidence of lung cancer in the United States is by quitting smoking. And there's even data that if people cut back on the number of cigarettes they smoke, they will lower their risk. It won't be negligible, obviously, but continuing, less is more, as we say, in terms of if you can just even cut back by half, you're doing yourself a favor, you're lowering your risk. Ideally, quitting altogether is huge. But I know a lot of people get scared to do a screening test because they're afraid they're going to find something. But the whole point is if we find it early enough, we can cure you. So.
Yeah. When patients come to you, there's an addiction component. I'm seeking help for quitting. What programs do we have here at Rush to help patients quit smoking?
Within the Department of Preventive Medicine, there's definitely people available to help with that. There's the Illinois Quit Hotline. Individual providers also give a lot of counseling. I know that I am always talking to people and trying to convince them of the benefits of it, and we strategize. Obviously, there are some mostly over-the-counter tools available in terms of gum and patches, and there are some medications that work a little bit. They're not my big favorite, but at any rate, but there are ways that we can talk through and help people come up with a plan, a quit date, and get them committed. I always tell them it's the best thing they can do for themselves.
Yeah.
Yeah.
Oh, and so with the holiday coming up, Thanksgiving will be around families, and will you be sort of taking this message on the road wherever you're traveling about the importance of consider smoking, or not to consider smoking, consider quitting.
Quitting smoking. I was about to say, thankfully, none of my immediate family smokes, certainly, in terms of things. I have some in-laws that have or do, and so maybe they'll hear this message, so, yeah.
We do have one question from the online audience, and so this is great, thank you. Do you have to have a physician referral for this screening?
Ooh, for Rush. That is a good question. I actually don't know. I know that Rush does have a self-pay option that is pretty affordable. I believe it's $139, but I don't know where the order, I don't know. I'd have to get back to them. I'm not sure on that.
Okay, I'm
Yeah.
sure we could add that information to the
Yeah.
chat later. And certainly want to direct people to rush.edu to find out more about primary care, find a primary care at Rush, as well as information about lung cancer awareness and screenings. And so I don't see any more questions coming through.
Okay.
And this has been good. And so happy holidays.
Thank you.
Anything that you want to say to the family now that we're Facebook famous?
You're all helping me with Thanksgiving dinner.
Awesome. Thank you so much. It was nice to
It was my
chat with you
pleasure.
today.
Thank
It's
you.
great.